how are you? So we have come up with a new series of 30 questions in 30 minutes. So what is the agenda behind it is that we'll try to cover the topic in a way that we cover maximum questions which have been asked previously in 5 years in both INICET and NEET. So we're trying to make maximum in this month so that we can give maximum output in the INICET. So in 30 durations, we'll cover the topic whole solely. Okay, so let's start with it. Today's topic is infertility. Now, what is the definition of infertility? Definition is if there has been no pregnancy with an unprotected intercourse even after 1 year. So 1 year is important. So even after 1 year, if there has been no pregnancy, that is definition of infertility. But question is, when will you start the evaluation? Now this was the question which was asked this year NEET, that when will you evaluate a patient who has no major symptoms and who is less than 35 years. You will not evaluate her unless it has been 1 year surpassed of her marriage. Okay, so absence of conception after 12 months, then you will evaluate her in case she is completely normal. This 12 months is reduced to 6 months when female age is more than 35. So if she is more than 35, you will evaluate her if she has not been pregnant since 6 months. Okay, this is important. Question asked was this one. The patient was completely asymptomatic, normal age, normal BMI, and she was, I think, 2-3 months pregnant. Then what was to be done? That was the question. So nothing. You have to wait for 1 year. In more than 35 years, you have to wait for 6 months. Now, there are certain cases in which you have to go for immediate evaluation. Like if a female is 40 years, the time you have with yourself, the fertility span is less. So you will not wait in her and you will do immediate evaluation in her. Likewise, if patient has such specific features, you can see there is an abnormality. You will not ask her to come after 1 year. Like if she has abnormal menstruation, or she had a history of radiotherapy or pelvic surgery, or she has excessive hair growth. In males, if there is coital difficulty, you will not ask such person to come after 1 year. These are the cases in which you will do the immediate evaluation. Okay, so this was the question asked this year NEET. Now, so how will you evaluate? Now, when an infertile couple comes to you, you majorly see 3 things. You see semen analysis, you see ovulation, and you see tubal patency. So these are the 3 things. Other things you see like the cervical mucus type and then the uterine cavity, they are miscellaneous. Once they all have been normal, then you go for other workups. But the 3 major workup which you have to do in an infertile couple is semen analysis, ovulation, and tubal patency. Let's cater them one by one. So let's talk of male infertility. A lot of questions have been asked in past 3 years from male infertility. So before starting male infertility, know this normal physiology. Like in females, every month a new cohort is picked up from the follicular pool. A new cohort of follicles is picked up. They undergo maturation. In the end, 1 follicle forms. In males, every 16 days, a new cohort is picked up. Okay, in every 16 days, a new cohort of sperms comes into maturation. How much time does it take? So 70 days it takes from formation of spermatozoa to sperm. So formation of spermatozoa to sperm is 70 days. Another 12 to 21 days it takes during the travel from epididymis to the ejaculatory duct. The sperm takes another 12 to 21 days. So this is the duration taken by sperm to become completely active and ready to go into female genital tract. Okay. Once it has been ejaculated out, 2 minutes is the time which a sperm takes from vagina to the tubes. Now, important, on which question has been asked? On capacitation. So what is capacitation? Once the sperm has been formed from spermatozoa, there are 2 types of maturation which are needed, which we can call extra-testicular maturation, so that a sperm becomes mature enough to fertilize an ovum. These are called as extra-testicular maturation, which occur in 2 phases. So first phase of maturation occur in the epididymis. So epididymis, initiation of maturation occur in which it attains hypermotility. The sperm is not very motile when it is released from testis. It attains motility in epididymis. And the epididymis has various parts, head, body, tail, okay, cranial part, caudal part. In all these parts, when it is passing through, it keeps on undergoing maturation. But the question asked was, the most mature sperms are found in which part of epididymis? It is the caudal part, the tail part. In the tail part, you will find the most mature sperms when taken out. Okay, so it undergoes maturation whole through its travel in epididymis, but most mature are in the tail. Does that mean capacitation is occurring in epididymis? No. Capacitation is different. Capacitation is when it attains ability to undergo acrosome reaction. it undergoes ability to penetrate zona pellucida. That is capacitation. Capacitation does not occur in epididymis. Question was asked, capacitation occur in female genital tract. It starts in cervix and ends in tube. If specifically asked, suppose both of them are in the option, where does capacitation occur? Your answer will be tube, because final capacitation occurs in tube. Okay, and as such it occurs in female genital tract, not in epididymis. Okay, right. Now, normal semen analysis. So any male infertility evaluation start with semen analysis. Recent WHO 2021 has changed its parameters, and the question has also been asked. So question on the semen analysis parameter has been asked in 2017 AIMS, 18 AIMS. There they asked which is the most important parameter. Among all these semen parameters, the most important is morphology. It is the most important parameter. In 2021, the question asked was, what is the normal morphology? Okay, so remember in 2021, WHO has updated its parameters, but morphology is same. It has to be more than 4%. So this is same, and this was the question asked in 2021 itself. Now let's see each one of them. So normal semen volume was initially 1.5 ml, but now it is 1.4 ml. Sperm concentration should be more than 16 million per ml. As previously it was 15, now it is 16. Total motility should be more than 42%. Previously it was 40%. So these are previous value I'm writing. Active motility, actively motile should be more than 30%. Previous was 32%. Very small changes, but remember these numbers. Okay. So there has been no change in morphology. Morphology has to be more than 4%. There has been slight change in motility and the sperm concentration. White blood cell count should be less than 1 million per ml. Now, if there is problem in volume, volume is less, of semen volume is less, it is called aspermia. If sperm concentration is less, it is azoospermia. Okay, what it is? Azoospermia or oligospermia. Okay, oligozoospermia. When zoo is ended, it means they're talking about spermatozoa. Then they're saying only aspermia, it is semen. Then if the motility is less, then it is called as asthenospermia, weak sperm. If the morphology is abnormal, more than 4% of them are not normal, then it is called as teratozoospermia. Okay, so these are the terminologies used if any of these parameters is abnormal. Remember these parameters. Now, causes of azoospermia. Now, a male comes to you with azoospermia. Now, you have to evaluate causes. Cause could be pretesticular. Okay, pretesticular means somewhere centrally related. It could be testicular in the testis, or it could be post-testicular. So, let's see the pretesticular first. So, question has been asked on pretesticular azoospermia in 2022 and 2017 both. Okay, so what was exactly the question? So, pretesticular, what do you mean? Means there has been some problem either in hypothalamus or in the pituitary, due to which gonadotropin secretion is less. As a result, the testis is not working. How the patient will come? Patient will have azoospermia, testosterone level will be less. What is less? Means less than 300 nanogram per dl. That is less. Okay, normal testosterone level is 300 to 1000. Anything less than 300 is abnormal. So less testosterone, azoospermia is there, plus FSH and LH are low. It is hypogonadotropic. Okay, now you will start evaluating this man again. Now you know it is central cause. So very common cause like in female infertility is pituitary adenoma, that is prolactinoma especially. So you will evaluate always the prolactin levels. And what will be your prolactin levels if it is abnormal? They will be high. In high prolactin levels, you will find this condition, and that was the question. So prolactin will be high, FSH-LH will be low, then it is hypogonadotropic hypogonadism. Also, you will get her CNS evaluation. You will get either MRI or CT scan for her pituitary evaluation. So that is how you will evaluate such a person. And how will you treat? Obviously, if it's a treatable cause like a tumor, you will treat according to the cause. If it is a non-treatable cause, then you will give the gonadotropin injections. You never give testosterone injection to the person of azoospermia, because testosterone will go and will cause complete shutdown of your HPG axis, hypothalamic pituitary gonadal axis. Okay, testosterone is never given. You will give gonadotropins. Okay, now, so this was the pretesticular cause, and this was the question asked. Now, let's come to the testicular cause. The question on testicular cause was asked in 2021. So basically, testicular cause, how a patient will present. Patient will have azoospermia. Okay. Then you will evaluate further. You will see that the testosterone level is less. You will see the FSH-LH are high. It is hypergonadotropic. Okay. So high FSH-LH is hallmark of gonadal failure. Either it is a acquired cause or it's a congenital cause. Testicular failure will be hypergonadotropic hypogonadism. Acquired cause could be varicocele. It could be mump orchitis. It could be undescended testate. It could be scrotal surgery. and congenital causes are the chromosomal aberration. Among the congenital causes, the most common is Klinefelter. So Klinefelter has been seen in 2/3 of the congenital causes of testicular failure, and that was the question. Okay, so how the patient will present? FSH-LH high and testosterone level less. How will you evaluate such a patient? If a patient has high FSH-LH, low testosterone, so you know problem is in testis. If it's an acquired cause, you can see varicocele, you can see undescending testis. How will further evaluate if clinically it is not detectable? Will you do testicular biopsy? No, because in testicular failure, testis is small and firm that can be clinically palpated. A failed testis, testicular biopsy will not reveal anything. You will not get sperms, you will not get, it's diagnostically and therapeutically it is not needed. So in testicular failure, testicular biopsy is not indicated. What is indicated? Genetic evaluation. You will do genetic evaluation to rule out congenital causes, okay, among which most common is Klinefelter syndrome. How the patient of Klinefelter will present? So question was asked that it's XXY and what other symptom besides infertility patient will have. Since it's an extra X, patient will have broad pelvis. So there will be broad, wide hips, broad pelvis. Patient will have long hands, long and wide hands, wide palms. Breast development will be there. Less chest hair will be there. Patient will have poor beard growth. Besides, small testes will be there and long arm and long legs. So these are the external features. This is how a Klinefelter patient will look like. And this was the question asked in 2021. Okay, so this is a common congenital cause of testicular failure. You will not do testicular biopsy. Patient will need genetic evaluation. Okay, post-testicular causes. So post-testicular causes means there is somewhere obstruction either in the epididymis or the vas deferens or the seminal vesicle or ejaculatory duct. Somewhere the obstruction is there. Now it could be obstructive and non-obstructive. Majority time it is obstructive only, but it could be non-obstructive. What are the examples of non-obstructive? Post-testicular causes non-obstructive. Immotile cilia syndrome, Carter Jenner. So it is not obstructive, but problem is post-testicular. There is problem in ciliary motility. Other than that, retrograde ejaculation. So retrograde ejaculation, there is no obstruction, but the ejaculation is occurring retrogradely, and that is why there is oligozoospermia. Where will you find retrograde ejaculation? In diabetic patient and post-surgery patient. When there has been surgery on the scrotum, there the retrograde ejaculation will have. Patient will characteristically tell you low semen volume, and you will see urine for any sperms. Okay, so these are non-obstructive causes. Obstructive causes are very common in post-testicular causes like congenital bilateral absence of vas, bilateral or unilateral, anything it can be. Ejaculatory duct obstruction, vasectomy, they all are the post-testicular causes. Okay, now how the patient will present? So patient will have, again, patient has azoospermia. Testosterone level, it will be normal. Why will testosterone will be affected? So it is normal hormonal profile. FSH-LH, normal. Okay, FSH-LH will also be normal. And if it is congenital absence of vas, you can see it clearly. Okay, you can palpate vas in the scrotum. So if it is there, it is clinically diagnosable. You do not need anything else. If it is not possible, you are not able to diagnose. If hormonal profile is normal, you have to see where is the obstruction. You will get a rectal ultrasound. If rectal ultrasound is also not telling you where the obstruction is, it might be the non-obstructive cause. What will you do? You will go to a testicular biopsy. The obstruction somewhere maybe in the testis also. So here the testicular biopsy role will come. If azoospermia patient with normal hormonal profile is there, then you will go for testicular biopsy. Okay. Now, question on congenital absence of vas deferens was asked in INICET 2022. So, if a patient has been diagnosed as congenital absence of vas, bilateral or unilateral maybe, anything, how will you evaluate such a patient? First of all, congenital absence of vas is 10 to 20% time associated with renal agenesis. So, you will get renal scan in all such patients. Always. Congenital absence of vas deferens has very strong association with cystic fibrosis. So, will you check this male for the mutations of cystic fibrosis? No, because many mutations are not even detectable. You will consider this man as cystic fibrosis and you will test the female partner. Okay, so a patient with congenital absence of vas, you will not check that person for cystic fibrosis. You will directly check the female partner. Why? If she is carrier of cystic fibrosis, then both the couple will need genetic evaluation because the kid can have cystic fibrosis, full blown. Okay, so you will consider this person as carrier of cystic fibrosis and you will check the female partner for any mutation. This you will do. Testicular biopsy? No. In bilateral absence of vas, It is for diagnostic testicular biopsy, you do not need. Okay, diagnosis can be made clinically. You will not be able to palpate vas. Biopsy, or you can say sperm retrieval, is needed because patient will need IVF. Now patient will need IVF, that is why you will need sperm retrieval. Okay, that could be from the epididymis or that could be from the testis. And another thing, how the patient will present. So generally, when there is bilateral or unilateral absence of vas, there is agenesis of seminal vesicle also. So seminal vesicle is also there, which is agenetic. As a result, the semen volume is less. Semen pH is also less. Because what is the work of prostate and seminal vesicle? They make the pH alkaline, so that it can easily enter and counter the acidic pH of cervix, right? So in case your seminal vesicle is agenetic, which is very well associated with absence of vas difference, the volume of semen is less, the pH is less, and the fructose level are also less. This was another option in the question. Okay, so this is how the patient of bilateral or unilateral absence of vas difference will present to you. Okay, so this was the post-testicular cause. Now another thing is vasectomy reversal. So vasectomy reversal, I just want to mention a little about vasectomy reversal here. So if the vasectomy has been done, the success of reversal rate is high, almost 80 to 100%, and it is inversely proportional to the time since when vasectomy has been done. So it means more than 15 years have been passed since when the vasectomy was done. Your reversal rate is not very good. It is inversely proportional. It is not that in the female tuboplasty when you do. Okay, it is inversely proportional to the time. And when will you say vasectomy reversal has been failed? If you have done the surgery of reversal, even after 6 months, there are no sperms, you will label it as vasectomy failure. Your procedure has failed. Okay, so these are the post-testicular important causes: bilateral absence of vas and vasectomy reversal, about which it is important to talk of. Now, since male infertility we have seen the gonadotropins can be given and you will treat according to cause. You will never give testosterone. Majority of time, if the azoospermia is less and it is not treatable, you will need artificial insemination. You might need ICSI, you might need IUI. The question was asked, artificial insemination and ICSI both in NEET. One question was asked on this testicular failure. So one question was asked in INICET 2021 was, how will you differentiate between testicular failure and obstructive cause? You tell me, how will you differentiate whether it's testicular failure or obstructive cause? Will you do biopsy? No. Simple hormone levels. If FSH, LH are high, it is testicular failure. If FSH, LH are normal, it is obstructive cause. Right? If FSH, LH are normal, you are not able to find obstruction, then you will go for testicular biopsy. But it is not needed for diagnosis. Okay. So how will you differentiate? By gonadotropin levels. Okay. Right. So artificial insemination, let's start with IUI. So IUI is intrauterine insemination of sperm. So you inject sperms intrauterine. Where it is done? In severe oligospermia? No. That was the question basically. The indication of IUI are coital dysfunction and unexplained infertility. When you do not know, everything is normal since till the patient is not becoming pregnant, or there is coital dysfunction. That are the two indications of IUI. Why? Because for doing an IUI, you need a actively motile sperm concentration of 5 to 10 million. If it is severe oligospermia, if sperm count is very less than 5 million ml, you cannot do IUI. So IUI ka indication are only to unexplained infertility and coital dysfunction, because you need these many sperms, 5 to 10 million actively motile sperms. Morphology also is needed to be normal. If morphology is abnormal, you cannot do IUI. This is very basic in IUI. Okay. So what to do if there is oligospermia, if there is severe oligospermia, or if you have taken the sperm from the testis. Now, as you see, as I have told you, post-testicular maturation is needed in epididymis and female genital tract. Now you have taken the sperm from the epididymis or the testis. Now what will you do? Can you just do IUI? You cannot do, because it is not motile, it is not perfectly active. Here you will need ICSI, intracytoplasmic sperm injection. So ICSI is the method of choice which is done when your motile sperm count is less than 2 million. If it is so less, answer is not IUI, answer is ICSI. So these both questions, how many sperms are needed for both procedure, was asked in NEET. Okay, yeah. So motile sperm count needed is less than 2 million in ICSI. Motility, if it is less than 5%, then also ICSI will work. Or you have taken surgically, the sperms you have taken surgically which have not undergone maturation, then also you will need this. Or conventional IVF failure, then you will go for ICSI. Okay, yeah. So this was all about male infertility. Now let's talk of female infertility. So female infertility basically is, you will test basically two factors, ovulation and Tubal Factors. Third is miscellaneous. If everything is normal, then you will go for uterine cavity evaluation and other things. But main you will take for ovulation and Tubal Factors. So let's see the ovulation. So remember the fertile window. Fertile window is of 6 days. Day 10 to day 17. Why fertile window in a female reproductive cycle is of 6 days? Because the lifespan of sperm is 5 to 7 days. And that of ovum is only 1 day. Now this has been again a NEET question. That 5 to 7 days is the time a sperm will survive in female genital tract. And ovum will survive only for 1 day. So the 6-day window is that fertile period which will end on the day of ovulation. When the woman has ovulated, that day the ovum will survive only for that 24 hours. So that day your fertile window will end. Okay. Now, so that's we have discussed. Now, how will you test for ovulation? If question is asked, what are the tests for diagnosing whether a woman is ovulating or not? These are the one. So first is the menstrual cycle. A woman who is regularly menstruating, you do not need to do any test. She is ovulating. First sign of ovulation is menstrual cycle. Another, if she is not ovulating regularly, is irregular, then next you can do is basal body temperature. There is a rise due to progesterone. You know that. Mid-luteal progesterone. So mid-luteal progesterone question has been asked on this in 2020. Mid-luteal progesterone is the best test for diagnosing ovulation. Whether the ovulation has occurred or not, for that the best test is mid-luteal progesterone, and progesterone more than 3 nanogram per ml will diagnose ovulation. And when will you do? 7 days before expected menses. So in a 28-day cycle, on what day? 7 days before menses, means 21 day. Day 21 progesterone, that was the question, is the best test for diagnosing ovulation. For diagnosing. Okay. Cervical mucus another way, because cervical mucus post ovulation is more slippery and stretchy. Okay. LH surge kit is also a very good test, but for diagnosing ovulation, no. It is the best test for predicting ovulation. If you want to predict the ovulation kab hone wali hai, when should I do IUI or when should I ask my patient to stay together, that for predicting ovulation the best test is LH kit. Important that LH surge which occurs before ovulation is staying for only 12 hours. It stays only for 12 hours. That is why this test has to be done twice a day. Okay, you will test with kit twice a day, and when you will start 3 days before expected surge. So if it's a 28-day cycle, you are expecting a surge at almost 14 days, you will start 3 days before. So you will start 10 to 11 day LH. Okay, that's how you calculate. Okay, question will give you how many days cycle is there. So 3 days before expected surge, you will do LH, and 7 days before next menses, you will do progesterone level. It is the best test for predicting ovulation. Another test is ultrasound. Now, ultrasound is expensive and cumbersome, but as such, it's a good test where you can see ovum increasing in size to almost 16-17 mm and then finally rupturing and corpus luteum formation. So this can also diagnose ovulation. Okay, anovulation. The most common cause of anovulation is PCOS. Okay, so this was a past NEET question. So most common cause of anovulation is PCOS. How will you manage? This has been asked separately in NEET. How will you manage? I think in 2021, patient of PCOS infertility, how will you manage? So first, in any PCOS patient, first is weight loss. Lifestyle management and weight loss is the first step. Then ovulation induction drug. What is ovulation induction? A patient who is not ovulating regularly, you are trying to make her ovulate. So you want single follicle to form and rupture, and you want her to ovulate at a predictable time so that you can do timed intercourse. So that is ovulation induction. It's not ovarian stimulation. We'll discuss later. So weight loss, then ovulation induction drug. Clomiphene citrate and letrozole. Letrozole is your first choice. It is aromatase inhibitor. Why it is first choice? Initially, clomiphene citrate, which is a selective estrogen receptor modulator, was the first choice. But then it is shifted. Why? Because clomiphene citrate has selective estrogen agonist response. It means somewhere it is agonist, somewhere it is antagonist. It has antagonistic action on endometrium and your cervical mucus. So ovum formation in both of them are same, but fertility, pregnancy rate are less with clomiphene because it has negative effect on your endometrium and on your cervical mucus. So basically in INICET 2021, a detailed question on clomiphene was asked. So first option was that it has negative effect on endometrium and cervix. Second, how does it act? So it's a receptor modulator. It goes and acts on hypothalamus. On hypothalamus, it inhibits that negative feedback which estrogen is putting. So it inhibits that negative feedback. As a result, the GnRH pulsatility rise. So it does not act on pituitary, which was there in option. It acts on hypothalamus, increase GnRH pulsatility. Okay. What kind of response is it? Monofollicular or multifollicular? There the difference between stimulation and induction comes. Ovulation induction means the patient ovulate nahi kar rahi, you will give her medicine so that she can ovulate regularly or timely. You want monofollicular, only single follicle to be formed. So ovulation induction drugs, clomiphene and letrozole, both are monofollicular. Whereas ovarian stimulation is, you want so many follicles to be formed which can be taken out of the body and you can take those ovum for IVF. That is ovarian stimulation. You are doing excess stimulation of the ovary. Here you want multifollicular response, which is given by GnRH. GnRH is used in IVF because they give multifollicular response. Clomiphene and letrozole for ovulation induction, they give monofollicular response. Okay? Yes. I have talked to you in detail because in detail the question was asked about clomiphene. Okay? Yes. So if the clomiphene and letrozole does not give you response, insulin sensitizers can be asked. This was the NEET question. What is the management step in PCOS and infertility? Metformin was one choice. So conflicting results, but since insulin resistance is the pathology in PCOS, if you add metformin, results are better. Okay. Gonadotropins. Your next step is gonadotropins. Though they give multifollicular response, so strict monitoring is needed. Why? High chance of OHSS and multiple pregnancy. But gonadotropins is the next choice. And if it is also not helping, you can go for surgical ovarian drilling. You drill holes in the ovarian follicle. As a result, patient starts ovulating because the androgenic environment surrounding the ovary, it comes down. So that's what you do. Another option which was given in PCOS question was tamoxifen. So tamoxifen is also a selective estrogen receptor modulator. It is also some places used for ovulation induction, and it has been said that it is better than clomiphene as it does not have antagonistic action on endometrium and cervical mucus. And it has been seen that it does not cause endometrial cancer because if it is used for very less duration. But it is not very widely used because the researches are still happening. So one option was tamoxifen. Tamoxifen can be used. Okay? Yes. Risk with gonadotropins. Since gonadotropins give you multifollicular response, there is risk of multiple pregnancy very high, 15%. As such, multiple pregnancy naturally risk is 1 in 80. Now here it is 15% and OHSS. Multiple times. Now I cannot tell you how many times this image has been given. This is cartwheel appearance of hyperstimulated ovary, OHSS ovary. Can you see two ovaries with so many big follicles? This is OHSS. Generally options given are very easily differentiable, PCOS and all. One option which is given is theca lutein cyst. Guys, theca lutein cyst bhi aisi hi dikhti hai. So how to differentiate between them? Theca lutein cyst has similar cartwheel appearance by the history. Patient of IVF given gonadotropins, it's OHS. Patient pregnant giving grape-like structures, passing to grape-like structures through vagina, theca lutein cyst. Do not mark OHS, okay? Because they both look same. You have to differentiate based on history. Okay? Many times the question has been asked on it. Right? So these are the two risks. Now what is happening in OHS basically here? Basically in OHS kya ho raha hai ki because of hyperstimulation of ovary, your vessels become hyperpermeable and all the fluid leaks out into the extracellular compartment, leading to ascites, pulmonary edema. Okay, so OHS has grades from mild, moderate, severe depending on how much fluid has been collected. So if you judge that OHS is about to happen, what will you do? Now this was the question asked in NEET, that see, if you're going for ovulation induction, you're giving simple ovulation induction and estradiol level is more than 1000 picogram per ml, you are going into OHS. Okay, because single follicle will lead, single follicle secrete only 400 picogram per ml of estrogen. If you're getting so high, you are going into OHS. In that case, either cancel the cycle. So cycle cancel means you will not give HSG injection. HSG injection is given for final maturation. That LH surge is mimicked by HCG injection. So you will not give that injection. You will cancel the cycle. If patient is affording, you can ask कि भी बहुत सारे follicles बन गए, convert it into IVF. Means let us aspirate your follicles and we will undergo IVF. Okay. So these are your options. So main is cycle cancellation. Cancel the cycle and in next cycle give less aggressive stimulation. So the question asked was that patient has got almost 800 picogram per ml of estrogen, estradiol on ovulation induction and multiple follicles are seen. What will you do? You will cancel the cycle. Okay. This is your question. Now test for ovarianism. If you are giving ovulation induction to a patient, she is just not responding. Now it comes the role of ovarian reserve. What is ovarian reserve? You want to see how much is the follicular pool. Now we have a pool of follicle which is formed in intrauterine life itself. Now from this pool, every time some follicles are picked up and they undergo maturation, seeing that pool, quality and quantity wise both is your ovarian reserve. You want to see if I'm giving stimulation, I'm not getting result. Is the pool good? That is ovarian reserve. How much is the follicular pool I am having? And what will it tell you? It will tell you how nicely your ovaries will respond to gonadotropins. That is the only thing it will tell. It will not tell about menopause and anything else. It will just tell you that your ovary will not respond very nicely to gonadotropins. Okay. So let's see test for ovarian reserve. Now ovarian reserve markers have been asked in 2021 and specific marker AMH has been asked in 2022. So these are the methods for ovarian reserve. Day 3 FSH and estradiol. So day 3 FSH more than 10 indicates your follicular pool is not good. Why day 3? Because at day 3 estradiol level is less. So negative inhibition is less. You can see get the original FSH level. That is what is done at day 2 or day 3. Clomiphene citrate challenge test. Nothing special. You give clomiphene and then you check for these hormone levels. Okay. So they both have low sensitivity. Inhibin B is secreted from the follicular pool. That can also be used, but again it is very low sensitivity. Good test is AMH, which is very commonly done. It has very high sensitivity, but the best thing is AMH is a glycoprotein secreted from pre-antral follicle, very early antral follicle. Okay, so we have read in basics, follicles have stages, antral, pre-antral. Early follicles secrete AMH and they are not FSH sensitive. Okay, they are gonadotropin insensitive. We know that antral stage where antrum, cavity comes in the follicle, they become FSH sensitive. Before that, it's not sensitive. As a result, AMH secretion is not affected by in which phase of cycle you are. You can do it anytime. You do not need fasting. You can do it in any day of the cycle. That's the best thing about AMH, and that has been asked multiple times. Okay, it is not affected by any day of the cycle. It is secreted by pre-antral, early and pre-antral follicles. Okay, less than 1 means your AMH is less, means your ovarian reserve is less, means you will not respond nicely to gonadotropins. That is the significance. If your follicles are too many, if your AMH is high, means more than 4 to 5, it means, what does it mean? You have too many follicles. It means you are a PCOS patient. And what does this mean? You have a high tendency of developing OHSS. You have so many follicle reserve already in your ovary that if you are given aggressive gonadotropins, you will develop OHSS. So that is the significance of OHSS. Less than when, poor response, that was the question asked in NEET. What is the normal level of AMH? So less than 1 is poor response, more than 4, 5 is hyper response. Okay, between is the normal range. Now, so these are the question asked about AMH. And yeah, another test is antral follicle count. Same follicles which are secreting AMH, you can count them on ultrasound. Now counting both the follicles on both the ovaries, if it is less than 4, it is again a poor response. Not very commonly done because ultrasound is doing it's cumbersome. Taking a blood sample for AMH is more easy. So this was the ovarian factors. Next comes the tubal factors. Question asked many times on HSG on both the images. Now tubal factors, tubal obstruction can be proximal or distal. Proximal obstruction, कैसे पता चलती है? You will do what test? You will do HSG, histosalpingography. You will do HSG, inject a dye, take the X-ray, and you will see this kind of picture. Can you see uterine cavity and everything? You cannot see anything beyond cornua. So it is cornual obstruction. Okay. Here you can see cavity, you can see thin tubes, but tubes are ribbon-like. They are dilated, and there is no peritoneal spillage. It means यहाँ पे वो रुक गया है. It means it's a distal obstruction. So this is proximal obstruction. This is distal obstruction. Which is more common? Distal obstruction. PID, tuberculosis, surgery. They all lead to distal obstruction, which is more common. Now, how will you evaluate? Suppose you get corneal obstruction. You will straight away treat the patient? No. See, when you are doing HSG, patient is wake. Patient is not unconscious. So it's a little painful procedure. What happens when you insert the cannula due to pain, spasm occur of cornua. So many times this figure is not of obstruction, it is of cornual spasm. That is why gold standard for diagnosing tubal obstruction is laparoscopy. If you find any abnormality in HSG, your next step is laparoscopy, not surgery. Okay, because now patient is general anesthesia and you'll know whether it was spasm or obstruction. Now let's see the management of each one of them. So proximal occlusion is less common. क्या होता है generally why proximal occlusion occur? Small flimsy adhesions होते हैं या फिर polyp or maybe a small myoma is there. So they are less common. And what you do? You just do a tubal catheterization. Tubal catheterization or cannulation is done. It was a past question and you can relieve this corneal obstruction. Distal obstruction. Now, distal obstruction due to PID or surgery or tuberculosis is difficult to manage. You have to do tuboplasty. All of them do not lead to hydrocephalus. This is hydrocephalus. All of them do not lead to this. But distal obstruction is difficult to manage. Tuboplasty rate does not have much success. So 85% of time this is the cause. Generally the treatment is IVF. Okay, you need to do IVF in majority. Question has been asked on hydrosalpinx in INICET twice. So what question has been asked? Hydrosalpinx means it's a distal obstruction. But after having distal obstruction, the fluid secretion starts occurring in tube. See how dilated they are. As a result, now the cilia of the tube and the endometrium lining of the tube is damaged. Now this tube is non-functional. You can, in a hydrosalpinx tube, tuboplasty will not help. Not at all. It is a non-functional tube. So the only treatment of hydrosalpinx is IVF. You will do IVF. But the question as what that has been asked is, see, there are secretions in these tubes. As a result, little seepage of the secretions occur, and if you do IVF, the chances of successful pregnancy are less. Always, if there is hydrosalpinx, before doing IVF, you have to remove these tubes so that inca secretion cannot affect your embryo and success rate cannot decrease. So that has been asked twice. Salpingectomy prior to IVF improve your implantation rate in hydrosalpinx. Okay, so that is done. If salpingectomy is not in given option, sometimes some surgeons, they just occlude this tube so that fluid cannot come. You can just occlude it also. Right? Okay. Last question. There has been a question in NEET on myomas. So role of myomectomy in infertility. As such, not a major role is there because myoma does not cause infertility. But if you have ruled out everything, ovulation is normal, semen parameters normal, tubes normal, then if you see a myoma, then role of myomectomy comes. Especially the location. Subserosal myoma will not affect the fertility. It has to be submucosal or intramural myoma. That too, one distorting the cavity. If it is distorting the cavity, then you have to do myomectomy. And large size, more than 5 centimeter will cause infertility. So large size myoma, distorting cavity, you can go for myomectomy. So the question asked was, there are 2 large myomas of 5 and 7 centimeter on the ostia. Okay, both are there. What will you do? So there, your option was IVF. No, you will not do it. You will do myomectomy. One option was uterine artery embolization. You will not do. Uterine artery embolization decrease your future fertility rate and increase abortion rate. You will never do in somebody who wants to get pregnant. UAE. Okay, so our answer will be myomectomy. Okay, so this was all about infertility. We have discussed in short duration of time. I hope I leave you with this good message and a good movie. We'll come up with next video to cover them as fast as possible. Bye bye.